Welcome everyone. I would like to introduce to my PhD topics which are involved around the benefits of clinical pharmacists in the healthcare system. I work as a clinical pharmacist and my vision is that every ward should have a clinical pharmacist due to their special education in medications, and to support this vision I would like to develop official clinical pharmacy services in Hungary. And throughout my practitioner years I provided clinical pharmacy services to ensure the patient's safety and to provide optimized medication therapy, which I would like to continue in my PhD project, which are interested in acute pancreatitis patients. First is to investigate a new combination therapy to add to the existing conventional therapy in patients with acute pancreatitis. The second project is question medication, PPIs, that is it necessary to give or not. And the third project, I would like to take a step back and see a broader picture of the position of clinical pharmacists in Europe. The first project is the combination of ulinastatin and somatostatin reduces the complication rates in acute pancreatitis. I got interested in acute pancreatitis because its incidence rate is low, however, it can have substantial mortality, and however, it's not a rare disease. There is no efficient pharmacon to this date. Somatostatin and its analog octreotide was used for decades, however, it has got controversial results, so no acute pancreatitis guidelines recommends its use in the daily practice. However, still in Western countries there is still used in daily practice, and in contrast in Eastern countries it is still used as a daily practice medication. And our aim is to investigate a fairly new drug called ulinastatin. It's a trypsin inhibitor. It inhibits the pancreatic enzymes. And it's based in mostly the Far Eastern countries, which adds it to the existing somatostatin therapy. Our question and our hypothesis is that this combination therapy is superior to the conventional monotherapy alone. After the selection process, we included 9 randomized controlled trials. In every investigated outcomes, this combination therapy proved to be superior compared to the monotherapy alone. It reduced the multiple organ dysfunction syndrome, the acute kidney injury cases, and acute respiratory distress syndrome. We investigated mortality. We did not have statistical significant results, only near significant. However, its clinical importance is substantial because the mortality halved by this combination therapy. And all these beneficial results are resulted in the decrease in length of hospital stay by 8 days. I should mention that in every outcome there is a moderate to high statistical heterogeneity. It is because the low amount of trials included in the meta-analysis or available in the literature, and due to the fact that every acute pancreatitis patient has different backgrounds and different comorbidities that can result in high heterogeneity. In summary, this ulinastatin combination with somatostatin analog resulted in a better patient outcome, which proves that it could be a viable alternative pharmacotherapy of patients with acute pancreatitis. This is the first meta-analysis in the topic. However, there are several limitations that we are aware of, that there is a small number of trials located only in China, the high statistical heterogeneity which came from the different therapy regimes, different follow-up times, and the different patients' background. The implication for research is there is a need for randomized controlled trials with larger populations, and to see whether it is cost effective to add to the therapy. Staying with patients with acute pancreatitis, I questioned the PPI use in this patient population because it is one of the most overused medication in the healthcare systems, and it's also true for patients with acute pancreatitis. On admittance, 20, and during the hospitalization, 70% of the patients have been prescribed proton pump inhibitors because mostly stress ulcer prophylaxis, and it coincides with its adverse or not wanted effect that it theoretically reduces not just the acid secretion of the stomach, but the secretion of the exocrine pancreas function, and it reduces the pancreatic juice in animal experimental models. However, it is not clinically supported, and in addition, no AP guidelines contains PPI-related recommendation or avoidance. However, it is the most used medication, and our aim is to investigate its effects on patients with acute pancreatitis, and we compared it to the conventional therapy, and we hypothesized that it is not beneficial compared to placebo. After the selection process, we included 9 trials in our systematic review. 6 of them are randomized controlled trials, 3 of them are cohort studies, which are more retrospective and prospective also. In every investigated outcomes, PPI seems to be not inferior nor superior as to the conventional therapy. Only we achieved statistical significance with the reduction of pancreatic pseudocysts. It decreased by 60% in the combination in the experimental group. However, I should mention that we combined randomized control trials with cohort studies. That mean we should take caution when interpreting the results. And also was true to the heterogeneity, that it has got moderate to high statistical heterogeneity due to the same reasons as the first project, the low number of available studies. In conclusion, to treat acute pancreatitis with PPI is an off-label indication, and however PPIs are considered safe. There are risks of adverse events mostly in the long term. The strength is that this is the first meta-analysis of the PPIs in acute pancreatitis. The limitations are that there are a small number of trials located again only in China, and there is high heterogeneity. The implications are randomized control trials with larger, carefully selected populations are needed. We had an interesting result about the risk of bleeding, that it seems to be that in the PPI group, the risk of bleeding is higher than the no PPI group, and we should see a cause-effect relationship because there are controversial results in the literature, and to investigate the direct effect on pseudocyst formation of the PPIs. And to take a step back, I would like to investigate the hospital and clinical pharmacist position in Europe, because clinical pharmacy services are not common in Central and Eastern Europe. It is mostly practiced by the Anglo-Saxon countries, Australia, United States, and in the United Kingdom. And there are no official benchmarking system for these clinical pharmacy services. This project is a multi-step approach. First, I would like to assess the position of the clinical pharmacy services. The second, I would like to give a systematic review in every investigated clinical pharmacy services to provide evidence-based guideline and benchmarking. And third, by this new benchmarking system, I would like to establish a registry that we can use to measure our impact on the patient care. First, the international survey, there are 3 sections of it. There is a descriptive section, clinical pharmacist relationship with the different healthcare workers, and about the clinical pharmacy services. And to end my presentation, I would like to give a brief project status update. In the first manuscript, we are waiting for an editorial decision. And the second, we are at the revision of the final manuscript with my supervisor and statistical methodology supervisor. And in the third project, it's an ongoing analysis. We are prepared with the final questionnaire, and we are before distribution of this among 4 major associations of pharmacies. And I would like to end my presentation with an old quote that never stop asking questions, and please feel now. Thank you.
It was a really nice presentation, and my question is pretty simple. Do we have ulinastatin in Hungary?
No, we are not, but we can acquire it from import. I looked it up, and we can import it from Japan. It costs around $100 per vial, and for the therapy, 1 vial for 1 day is the usual therapy. So we should look into it if it's acceptable or if it's feasible, but it would be a costly clinical trial.
I have a question about your first topic, that you had substantial heterogeneity regarding some outcomes, and you said that it's caused by different patient populations. Would it be feasible to conduct a subgroup analysis to see which patient population benefits most from this therapy? If it would be feasible, then I would done it. More randomized control trials would be necessary. However, there are certain aspects, mostly the complication rates that I have resolved. These are homogeneous population, which are the severe acute pancreatitis. However, we investigated all forms of acute pancreatitis.
I just wonder that, I mean, in a very different topic, but kind of similar number of studies with RCTs and other studies. I mean, we got the criticism from in a review that why did we do both both the RCTs and some other studies, because RCTs are the top of that. And so have you got the same kind of question, or I mean, during the review?
Yes. Yes.
Oh, okay. So what did you do then? I mean, you can get through on this, but yeah.
Yes, to get broad. So if we would use only randomized control trials, we wouldn't have enough results that we can draw a conclusion. PPIs are one of the most used medications. However, there are lack of evidence or lack of results. So I feel that there is a need for this result to be presented for the broader audience because it has adverse reactions in the long terms, and it could be substantial. PPIs, there were cases in the United States which resulted in deaths by using PPIs, and it should be avoided if it's feasible.
Yeah, I mean, I fully agree on this, but this is not only you and we, actually, but others will get the same kind of problem, and then just fight for that.